Ashley is a long-term eczema sufferer, a freelance writer and blogger of Edgin since 87, which highlights skin conditions with a particular focus on eczema. So, Ashley, please ask your questions.
Hi, thank you so much for having me, and good afternoon, everyone. I could talk about this all day. I'm so excited. I can't even mention how these conversations are making me so excited. You have no idea. But my first question, which you kind of answered a little bit, but as a patient and eczema advocate, I've had it since I was diagnosed when I was 2 years old, and I hear so many issues and concerns within the eczema community, and there's just so much information going on. As a dermatologist, what do you think would be the biggest challenge when treating patients when it comes to moderate to severe eczema?
Severe eczema. I think, Ashley, thank you for taking the time to be here today and for the questions. I think one of the biggest challenges I face as a provider is, especially for patients who have been dealing with eczema for a very long time, is having that initial discussion and understanding, what they think about their disease and, what has been the struggles for so long. And when patients come to see me for the first time, there's a lot of information out there, like you just mentioned, and a lot of that is misinformation or information that may not apply to them and it's not accurate. So patients typically come in, with all these questions and all these thoughts about their disease. And I think the most important, or perhaps the most challenging step for me is, finding the time to have that first conversation about what do you know about your disease as a patient struggling with it. What do you think it is that you have? What are your expectations? Do you think that this is a disease that should be gone by now, right? And it's trying to explain to patients that this is a chronic disease in many cases. And as soon as I mention the word chronic, you can see how their semblance changes a little bit into, oh, you're telling me I'm going to have this for the rest of my life? It's a little bit kind of like losing the hope there. But I think it's important that I'm very clear with them that if you have had this disease for such a long time, it's very unlikely that this will be outgrown. And we need to start thinking about it as a chronic disease. And it's not just about treating the flares, right, with an oral course of prednisone and that's it. It's also about coming up with a long-term treatment plan. And that might have been something that was a little harder to do in the past because we really didn't have many great treatment options. But the world is changing for eczema. So, the struggle I also see is when patients come in to see me and I ask them, what have you been doing with respect to treatment in the past? And a lot of them will say, oh, I just go to my dermatologist doctor or my primary care physician because I can't go get in to see a dermatologist. I'll get a course of steroids and then I'm fine for a few months and then it comes back worse and then I go back, I get more steroids or I go to the emergency rooms and they're in this loop of constantly being treated with oral steroids. And not being able to get off of it. And that is challenging, trying to convince, my patients to see the disease as a chronic disease that cannot necessarily be treated, on and off with steroids, that we need to come up with something better than that. Just because of the side effects of just dealing with steroid exposure long term, right? So I would say that's the biggest challenge, having that first honest conversation with our patients. And I think that if we take the time to do that initially, then it makes all the other conversations a lot better, a lot easier as well. So that I would say is the biggest challenge. I think one of the other challenges, particularly in the adult population, is making sure that I have the correct diagnosis. As I was previously talking with David, there might be some patients who just don't read the textbook for eczema, and their skin distribution of skin lesions are not where you would expect to find them. They don't seem to respond to topicals or orals the way other patients would. And in those types of patients, that's when I do take a step back, go back, review their history, review what their biopsies, and make a diagnosis before moving forward.
Right, absolutely. It's so interesting that you mentioned steroids because right now in the eczema community, it's kind of split. And there is a huge movement towards people not using steroids and the long-term effects that it had on people, probably my age, maybe a little bit older, a little bit younger, who have taken it for years and years and years when we should have never taken it for so long because it did so much damage. So I find that very interesting. Did you talk about the steroids? And now I feel like a lot of pharmacies are realizing that people that have taken steroids for so long are really, the side effects are just so bad that they're trying to come up with different treatments to that don't include or involve steroids. So that's very interesting. You previously talked about mental health with eczema, and last May was Mental Health Awareness Month, and I think eczema and depression and anxiety go extremely hand in hand. And I think a lot more people have been vocal about how they've been suffering and how eczema is debilitating and it's really taking control over their lives if they haven't had it managed. What are some suggestions for people going through this? What do you think that they could do to maybe help with their anxiety and whatnot? And you mentioned the word avoidance, which I find myself having that problem as well. Sometimes when you have such a flare-up, you kind of just avoid doing certain activities that you would normally do. But what would be your best advice for somebody or a group of people that are maybe going through things with eczema and they really have nobody to turn to?
No, I think it's great that you actually bring that question on the topic of depression and anxiety and eczema. And just to briefly provide some background information, there is a recent meta-analysis, which is basically a review or a systematic review of the literature, the studies that are out there that looked at the risk of depression and suicide in patients with atopic dermatitis. And the results were actually quite alarming from my perspective. It showed that about 1 in every 6 patients with atopic dermatitis met clinical diagnosis of depression, and 1 in 4 had symptoms suggestive of depression, and about 1 in 8 having symptoms of suicidal ideation, particularly in those patients with more moderate to severe disease. So this is definitely something that I think as physicians we do need to address more frequently in clinic. And as part of my discussion with patients, going over their symptoms, I do open up the question about depression and anxiety, and you would be surprised the number of patients who don't volunteer that information when you just ask them, well, how are you doing today? And their answer is, I'm fine. But then when you specifically talk to them about any symptoms of depression, anxiety, and suicidal ideation, they'll mention it to you. Yes, this is having an impact to me in that level. There's studies showing that patients with atopic dermatitis, particularly those with moderate to severe disease, actually do experience lifestyle changes, or do lifestyle modifications. And we can talk about, avoidance, not being involved, social interactions, even changing their line of work sometimes, or choosing an occupation that may not be their preferred occupation, but it's something that they feel they can do despite having eczema. So it does have an impact on their quality of life, and that needs to be addressed. I do recommend that patients who have eczema and are struggling with the symptoms, that you do need to provide that information to your provider in case your provider or doctor is not asking you those questions. You need to let them know. We do try to keep the avenues of communication with our patients pretty often. Initially, I will see patients very quickly in clinic, especially if they have moderate to severe disease and they're not very well controlled, because it's a way for me to establish a relationship with our patients. And then as I feel that their symptoms are improving, that their mood is also improvement, and then I would say, okay, we're ready to stretch our visits farther out. But it's important to bring those symptoms to your physician's attention if they are not asking you the question. What's interesting is that we don't really know if the association between depression and atopic dermatitis, if there is a biological association, right, a pathophysiological one, if it's because of the inflammatory burden, or if it's because of the impact that itch and sleep loss has in our patients' quality of life. Studies have shown that once you can improve the signs and symptoms of eczema, you can actually control the disease and improve the symptoms of depression or anxiety. So it might be that that's the reason why that's happening in the first place, and that if we can work towards achieving disease control, those symptoms should also improve as well. But definitely mentioning to the physician, opening up the conversation is critical.
That's great advice. Yeah, I have to say, I've sat in panels and I've read things online where, kids have been taken out of activities from school or just avoid going to school altogether because their skin is so bad and it really affects their mental health. I've read things about people not wanting to, have kids so that they don't pass on their eczema, just, really sad things, and it's so unfortunate. So that's a great answer. I know we're probably kind of running short on time. I just have one last question. The eczema community right now is just thriving. Like, so many people are coming out of the woodworks and all supporting each other and talking about, what they've been going through, and just excited for the opportunities that are upcoming. And so my biggest question would be, what do you think the trends are going to be for, I guess, the rest of 2019, 2020, and within 5 to 10 years within the atopic dermatitis community?
No, I think that's an excellent question. Before I just one mention about what we were talking about, patient support groups. And I just want to say the National Eczema Association is a patient advocacy group. So if patients are looking for someone to reach out to, some guidance and some recommendation, I would say that's a really great association to reach out to. In case you need to establish rapport with other patients who are suffering from atopic dermatitis, I think that would be a great forum to reach out to. So it's the National Eczema Association. I don't work for them, but I'm just thinking about our patients who are out there thinking about who to reach out to. They can reach out to them. With respect to treatment, you're right. The next coming years, people are talking about this being the decade of eczema, and it's because the more that we start to understand the pathophysiology of atopic dermatitis, the more that has led to development of more targeted treatment approaches. So in the past, treatment options were either oral courses of steroids, topical steroids. Then we got the calcineurin inhibitors like pimecrolimus, brand name Elidel, or tacrolimus, brand name Protopic. And then we had systemic agents that were not really FDA approved, but we would use for a lack of other alternatives like cyclosporine, methotrexate. In 2017, we had the first biologic approved for atopic dermatitis, which is called dupilumab, which blocks the action of interleukin-4 and interleukin-13. And that has actually changed the way we treat our patients with atopic dermatitis, because it's been allowing us, particularly me, to get patients off of steroids, not even having to use topical steroids. So that is my goal, to wake up one day and not have to use oral steroids or topical steroids to treat any of my patients. And the research is actually focusing on that immune dysregulation and restoring skin barrier defects. And there are going to be newer targeted approaches that are currently either in phase 1, phase 2, or phase 3 clinical trials that offer a targeted approach, meaning they will block different molecules that are driving the inflammatory processes, such as interleukin-13, interleukin-19, OX40, and the results look very promising. In addition to that, there are other molecules that are being studied in clinical trials, such as the JAK1 inhibitors or JAK-STAT pathway inhibitors that have been showing great results so far. And we think that once those medications do get approved, they are going to be life-changing. So right now, we are currently in the process of doing clinical trials and getting started on a trial with a JAK inhibitor. So we hope to offer that to our patients as well as doing trials with other more targeted cytokines like IL-33. So that will definitely, I think, be exciting for our patient population. And again, as I mentioned, my goal is that one day we're going to wake up and we're not having to use oral steroids anymore, just like we don't do steroids by mouth orally for psoriasis patients anymore. So that would be my goal for our eczema patients, and it is a very exciting time. And we're also seeing the development of new topical approaches to treatment, which also include topical JAK inhibitors, so that patients don't have to be using these topical steroids for such a long time and avoid the detrimental effects in the long run.
Thank you, Ashley, and thank you, doctors. I'm going to just take up a couple of questions from the audience. This has come twice. Why does eczema flare up at night?
So that's an interesting question, and there's studies doing on eczema, sleep pattern, and the circadian rhythm. When you ask patients with eczema, at least my particular patient population, when is your itch worse? And a lot of them will say, it's when I go to bed and start to fall asleep. And we don't know if it's because our minds are not as occupied during the day. We're not at work, we're not rushing around, or if there are actually some physiological changes in the circadian pattern. We don't really have the answer to that question yet, but I don't think so much that it's the eczema that's getting worse at nighttime. I think it's more the itching that's getting worse, and that triggers us to scratch, and as we scratch, then we cause more inflammation of the skin, and so on and so forth. But there is definitely studies showing that alterations in sleep patterns are associated. The relationship, we don't know in which direction it goes yet, whether if it's the eczema is not allowing me to sleep better, or if it's like the sleep alterations that I'm experiencing also could have maybe some form of pro-inflammatory effect that's affecting the skin. So it'd be interesting to see the results of those studies that are currently ongoing.
Thank you, doctor. Another one, can you touch upon use of monoclonal antibodies in drugs for treating atopic dermatitis? She has given a reference to the Novartis trial.
Yes, perfect. Okay, so with respect to other inflammatory skin conditions, I mean, when you look at psoriasis, we have about 10 biologics, give or take, that we could use to treat the signs of psoriasis, and before 2017, we had nothing for atopic dermatitis, and at that point, a new medication came about. It's called dupilumab. It's a human monoclonal antibody, and it blocks the action of interleukin-4 and interleukin-13. We do know that those two cytokines, interleukin-4 and interleukin-13, can promote inflammation, and this clinical trials show that patients who were treated with dupilumab, about 4 to 6 out of 10 patients actually achieved clear skin or minimally active disease, and about maybe 40 to 50% saw about a 75% improvement in their skin from baseline. So it has definitely resulted in a game changer for our patients. It's a medication that's safe and tolerable. I do counsel my patients on risk versus benefits, and we have a discussion. But compared to other currently available systemic agents, such as cyclosporine and methotrexate, and azathioprine or mycophenolate mofetil, the side effect profile is definitely better. Current clinical trials that showed the most promising results are in biological agents and monoclonal antibodies, and they include antibodies, as I previously mentioned, to OX40 ligand, interleukin-17, interleukin-33, interleukin-31, and those are molecules that are known to be important in the pathophysiology of eczema. We may have some patients in which IL-4 and IL-13 aren't as important, and it is only by blocking maybe one of the other ones that we can get their disease to improve. So that goes back to our discussion with David about the heterogeneity of the disease. So the results do look promising. The same goes for the JAK inhibitors. So JAK inhibitors are smaller molecules, which also help control the production of pro-inflammatory, molecules, and they've also shown promising results in early phase clinical trials. And we do think that they will be a game changer for our patient population as well.
Thank you, doctor. I just take one more question before we wrap up. Would improved or controlled atopic dermatitis mean no dementia or lower risk of dementia?
Yeah, so it's great that you asked that question. Recently, during the meeting for the Society for Investigative Dermatology, one of the researchers, Dr. Katrina Abubara, who is a wonderful colleague, and is doing great work on atopic dermatitis, she did a study, I think it's approximately using a primary care database of approximately 1 million patients, and as the lead author for the study, they did find that adults with atopic dermatitis compared to those who don't have atopic dermatitis have higher risk for dementia, also Alzheimer's dementia and vascular-related dementia. And these associations were still present when they control for other factors such as age, sex, and there was also a trend that they saw in that patients who had more severe disease had a higher risk compared to those with lesser disease. So it's interesting to think about how that's changing the way about how we think of eczema or atopic dermatitis, not just as a skin disease, but also as a disease that can a systemic disease, right, where the inflammation is not only on the skin, but it's also going inside the body as well. And so now the question becomes, well, if we can further prove that those associations with these types of systemic diseases like cardiovascular disease, dementia, celiac disease, if those associations are true, and then the question becomes, if we treat patients with atopic dermatitis, if we're able to control their inflammatory burden, can we somehow be able to modify the risk for developing dementia in the future or developing cardiovascular disease in the future? So I think that's going to be a question that needs to be answered in future studies.
Thank you, Doctor. I think it's a wrap now. Poor disease control plays a major role in the disease burden reported by the atopic dermatitis patients. The condition has social and economic repercussions as well. We've just heard Dr. Chiesa explain how atopic dermatitis can be managed better. Dr. Chiesa, thank you very much for your time and information shared. David and Ashley, thank you for participating and bringing the patient's perspective into the discussion. We also thank the University of Pennsylvania. The talk will be available on CureTalks.com. Please visit our website for details on upcoming talks. Thank you, everyone, and have a great evening.
Thank you.